Welcome back to Your Health television program. I'm Dr. David Morwood. I am a board-certified plastic surgeon, and I'm so very pleased you could join us for this next edition of Your Health television program, because my first guest is the distinguished Dr. Nevelle Udwadia, board-certified rheumatologist. Dr. Udwadia, thank you very much for coming back on the program.
Thank you very much for having me, Dr. Morwood.
Dr. Udwadia, it wasn't that long ago where you were kind enough to join us, and I'm delighted you could return. We touched briefly at that time during that program about joint pain and an introduction to arthritis. I want to back up just a little bit. I want to talk about your training and what it takes to be a rheumatologist. And of course, I want to give out your contact information. Then I want to get right into our very important subject, joint pain. So Dr. Udwadia, tell us how a doctor becomes a rheumatologist.
Well, thank you. Well, first one must finish medical school, of course, and then after which you have to choose the specialty of internal medicine, which is a 3-year training program, residency, internship, what have you. After which you choose the fellowship training of rheumatology, which is a subspecialty training for rheumatologists. It's either a 2- or 3-year program, which I completed back in 2003.
So Dr. Udwadia, I think it's important to emphasize that, of course, anyone who goes to medical school has to go through college. They finish college, and we get a BA or a BS, etc. Then 4 years of medical school. Now, in your case, you went through complete training for internal medicine.
Right, that's correct.
So you could have elected to go out and practice internal medicine. You could have been an internist. But instead, you elected to do additional fellowship training in rheumatology.
Right.
And for how long was that?
2 years in rheumatology.
2 years. Yes. In addition to your internal medicine training.
That's correct.
At residency after internship. So it's a lot of years to become the specialist you are. Dr. Nevelle, tell us where your current practice is. And before the end of the program, of course, I'm going to give out your contact information, certainly your phone number. So where is your office now?
Well, we have the pleasure of having 2 offices. One's in Monterey at the Hartnell Professional Center, and the other office is in Salinas on Abbott Street.
Okay. And you are, as I mentioned, a board-certified rheumatologist.
Yes.
So, Dr. Udwadia, what I'd like to teach the audience about, with your help, is this huge topic of joint pain.
Right.
Now, maybe we can start off by talking about joint pain in general. Now, does everyone who has joint pain have arthritis?
Right. Excellent question. You know, joint pain is often not isolated to the joint. It can be referred pain from elsewhere. It could be soft tissue rheumatism, meaning the muscles are involved, or supporting structures such as tendons and bursa are involved. And when those structures are involved, you can often have people feeling like they have an actual problem with the joint itself. However, the joint might be perfectly fine. It's the soft tissues / bursa or tendons that are inflamed and causing pain.
Okay, so Dr. Udwadia, let's say we have a so-called weekend warrior, that it's just a 45-year-old guy who decides to play some basketball with the guys at the club, and for 4 hours on a Saturday, they play basketball, and he's doing maneuvers that perhaps he doesn't do typically, and he may use muscle groups that he's not used to using, and Monday morning he has pretty significant shoulder pain, hip pain, back pain. Now, does that mean, by definition, that he has arthritis?
Most likely it doesn't. Thankfully, arthritis usually doesn't present that acutely. Someone who is not used to doing activity like this weekend warrior that you have described, plays some basketball or what have you, and then the next day comes down with soreness in his shoulder, he unlikely has arthritis. He most likely has overuse syndromes, either mechanical joint pain, as we call it, or sprain/strain syndromes that are very common in individuals who just start initially working out the wrong way. So it's very common to have those sort of things as well. He doesn't necessarily have arthritis.
Okay. Well, Dr. Udwadia, allow me to present a different scenario. Let's say we have a 55-year-old woman who, over the course of a few months, notices that in the morning she wakes up and her hands are somewhat stiff and a little bit swollen, and they seem to be actually somewhat painful for her. and as the day goes on, her fingers and joints sort of loosen up. Now, is that a different scenario, or would you approach that the same way as, say, the guy who worked out hard suddenly for a weekend?
This is a very excellent presentation of what we consider a suspicion for inflammatory arthritis. This is a middle-aged woman starts complaining of morning symptoms. Now, I assume that she doesn't have a overnight position where she's not a secretary overnight or working the night shift. Why would she wake up with morning symptoms? This part of your history is very important. The morning symptoms, where people wake up with morning stiffness that often lasts for more than 1 hour, and then actually they improve as the day goes on. They improve with activity. You use the words loosening up. This is very typical. Other things that lead us towards inflammatory arthritis, such as rheumatoid arthritis, are things such as, well, doctor, I've noticed some swelling in my hands. I find myself putting my hands in warm water in the morning to loosen them up, and then after that, I'm somewhat improved. So the scenario which you're describing is an excellent first place to start about thinking of inflammatory arthritis, such as rheumatoid arthritis, psoriatic arthritis, and things of that nature, as opposed to osteoarthritis, which is your wear and tear, if you will, genetic predisposition, if you will, or activity-driven arthritis that is very common in the population.
Dr. Udwadia, that's an excellent point, and I want to try to expand on that for our audience.
Yes.
Now let's try to teach the concept that there's a difference between the so-called wear and tear arthritis, osteoarthritis, and this inflammatory disease, rheumatoid arthritis, that may be related to an autoimmune disease or phenomena. Is that correct?
That's correct.
So let's take a couple minutes to talk about that wear and tear arthritis, whether it's in the shoulder or hip or ankle, as opposed to an autoimmune or inflammatory phenomena. Can we do that?
Sure. Well, what people have to understand is the word arthritis, this encompasses a wide variety of different scenarios, diagnoses, if you will. There are over 100 different types of arthritis. Now, it's very difficult during an office visit to sift through all 100 or more so arthritis. We try to stratify patients in two general groups: the inflammatory arthritis, such as rheumatoid arthritis, which is the number one type of autoimmune inflammatory arthritis in America, and non-inflammatory arthritis, which is the overall most common arthritis, which is osteoarthritis. And the way we separate these two are exactly as you alluded to. We start asking questions. So osteoarthritis is your genetic predisposition, your activity-driven, if you will, the joints that are more utilized, the more weight-bearing joints as well, okay? This type of arthritis is usually worse when the weather gets colder or when the weather gets damper, okay? These individuals can feel their joints hurting more because of slight changes in barometric pressure in their joints, as opposed to an inflammatory arthritis, such as rheumatoid arthritis, which is truly a disease in which the body is attacking itself for reasons we have yet to discover why, but it does not care about activity. It does not care about what you do or how much you weigh or the weight-bearing joints or what have you, things of that nature, activity-driven things. It cares more about when it gets activated. The morning symptoms really tend to edge out everything else with regards to that presentation. Also, it's an inflammatory arthritis. Therefore, truly not just tender joints, but also swollen joints are very important in helping decipher osteoarthritis or non-inflammatory form rheumatoid arthritis or inflammatory arthritis.
Okay, Dr. Udwadia, that's very helpful. But another scenario, let's say a 55-year-old man or woman comes in who's a carpenter, because of course that can be a man or a woman who's been a carpenter for, say, 25 years, and they're right hand dominant, and they estimate that 500 times a week they lift their hand over their head to bang in a nail, and they noticed after 25 years of doing this that their shoulder almost always hurts when they're working, but no other joint bothers them. Now, does lead you to think of osteoarthritis, wear and tear, or does that lead you to think of an autoimmune phenomenon?
That leads me to believe more in the world of osteoarthritis, and this is the reason why. You certainly have a middle-aged individual who has been doing this sort of activity for a long period of time. Therefore, the wear and tear concept comes into place a little bit. And number two, also, it's a monoarticular involvement, meaning one joint is involved, their shoulder, as you alluded to. Whereas rheumatoid arthritis, well, it's a systemic disease, so we would have certainly more commonly more than one joint involved, both sides of the body involved. And truly, it's difficult to diagnose rheumatoid arthritis without involvement of the distal extremities and the small joints of the distal extremities. The shoulder is a large joint. It's a monoarticular presentation, as you alluded to, and it's activity-driven, another thing you alluded to in your history. So I would have to significantly lean more towards mechanical/osteoarthritis in this individual.
Okay, Dr. Udwadia, this term that I want to go on to and try to educate our viewers about, when you talk about an autoimmune disease, now the lay person might say it's a phenomenon where the body is attacking itself. Does that make sense? Now, tell us about what we mean by an autoimmune disease.
Well, autoimmune disease is truly when the body, meaning the policeman cells of your body, the white blood cells as we call them, there's some aberrancy there. There's some, which we have yet to figure out, what we call this immunological tolerance, in which the body's policeman cells, if you will, for whatever reason, stop recognizing certain protein moieties in our body, and we are filled with trillions of different proteins. And when this lack of recognition occurs for whatever reason, that's when autoimmune disease is triggered off. We actually start shooting bullets at ourselves. We don't shoot bullets, we have what we call antibodies. And when we shoot antibodies at ourselves, these are called autoantibodies, those in which we shoot ourselves with. Now, we shoot bacteria and viruses with antibodies as well, but those are somewhat different. So autoimmune disease is a umbrella term which describes a slew of conditions in which the body stops recognizing certain entities within ourselves and starts shooting ourselves, causing a provocation of the inflammatory cascade, causing tremendous amount of inflammation in our body, which leads to devastating outcomes.
Well, that's fascinating, Dr. Udwadia, but give us some examples of autoimmune disease. I'll assume that includes rheumatoid arthritis.
Yes.
But give us some other examples of an autoimmune phenomena or autoimmune disease that's manifested in different ways.
Sure. So autoimmune disease is all around us, and every autoimmune disease doesn't have to be so terrible. For example, how many folks do you know who have a thyroid anomaly? We call this Hashimoto's thyroiditis, where their thyroid gland doesn't make enough thyroid hormone. That is an autoimmune disease in which the body has stopped recognizing certain moieties in the thyroid gland and have started shooting against our thyroid gland, not allowing the gland to make enough thyroid hormone. So there's one example. Then we have diabetes. That's an autoimmune disease. Then we have psoriasis of the skin, a very common thing, which I'm sure you have also dealt with in your career. Also, we have, as you'd mentioned, rheumatoid arthritis. And then in our world, the connective tissue autoimmune diseases, the things such as lupus and scleroderma and Sjogren's syndrome, and the different types of inflammatory myositis that I deal with, which is inflammation of muscle and muscle groups. These are also, thankfully rare, autoimmune diseases.
Dr. Udwadia, before we get on to some of the ways you treat these autoimmune diseases, including rheumatoid arthritis, I do want to mention, so far we've talked about adults and senior citizens, but isn't it true that even young people, even children, can develop a form of autoimmune disease and arthritis?
That's absolutely true. Unfortunately, the pediatric world is not immune to autoimmune disease, okay? So we have people with juvenile idiopathic arthritis. We used to call that juvenile rheumatoid arthritis, but that has changed in its description. That's an autoimmune disease. We have systemic lupus also in young individuals that can present with devastating renal failure at a very young age, a very sad scenario. So yes, autoimmune disease is certainly not a disease or group of diseases isolated to the adult population.
Okay, Dr. Udwadia, and you know, in the brief time we have left, and again, this topic is fascinating to me. I hope you come on again.
Thank you.
So we've talked about wear and tear arthritis, rheumatoid arthritis. We've talked about autoimmune phenomena, autoimmune disease, rheumatoid arthritis. So what can we do about these things, or is it just that the rheumatologist makes a diagnosis? Is there anything that we can offer to the populace that may have osteoarthritis and, or I should say, or rheumatoid arthritis?
Well, there are two sides of the story, and I'm very happy to say that, you know, the world has changed with regards to rheumatoid arthritis, and the world has changed with regards to rheumatology over the last 15 years. Many medications have come aboard that have helped lots of folks with inflammatory arthritis. Rheumatoid arthritis used to have devastating outcomes, people in wheelchairs and people who tend to have lower life expectancies because of their chronic inflammatory states. Now with the newer medications for inflammatory arthritis, their overall life expectancy is normal, and they actually lead normal lives, and many of us will never be seeing a patient in a wheelchair anymore from rheumatoid arthritis. The other side of the story, sadly, is osteoarthritis, where despite us having medications come down the road in an effort to help these folks, none of them have been successful. So it becomes a modality of activity modification, pain control, and patients understanding how they may be able to help themselves reduce their burden of pain from osteoarthritis. Common sense things such as keeping their body weight low and watching what they do with regards to how they utilize their hands or whatever joint is involved with osteoarthritis, and doing the best they can with the least amount of pain control.
Well, Dr. Udwadia, that's a fascinating topic, this joint pain, and we're very lucky, we're very fortunate to have a guy with your training in this area.
Thank you.
We are coming to a close of this segment. Unfortunately, I hope you come back again. But what I would like to do is give out your contact information. Again, Dr. Nevelle Udwadia, and your main office is here in Monterey, and you also have an office in Salinas. Do you have a phone number we can give out?
Yes, it's 831-373-7400.
Dr. Nevelle Udwadia, you're board-certified rheumatologist, expert in joint pain and rheumatology conditions, etc. 831-373-7400. Well, Dr. Udwadia, thanks so very much for coming on the program. I hope you find time to come back and teach us again.
Thank you very much for having me.
Once again, this is Your Health television program. I'm Dr. David Morwood. I am a board-certified plastic surgeon. We will take a very brief pause for a very good cause.